get our angle and everything, Ted?
Yes.
Okay. All right, you start it?
Yep.
Okay, we're gonna test for the knee. So again, clear the spine before you go to the knee. Are you gonna go to the one that they're complaining about first? More than likely. Are you gonna check the other one? It's your clinical decision as to whether you check the other one. Are you gonna also check the femur? That's your clinical decision. It's a kinematic change, so I tend to check the whole extremity when they're having a problem. But it is your clinical decision as to what you think that patient needs. All right, first I'm going to check for an anterior proximal tibia. Use a broad hand contact, not a finger or fingers, because that's probing and it hurts. So I'm gonna stress the tibia anterior and see if he becomes uneven. I've cleared the spine, so he should be even. So when I stress it anterior, if he's reactive, not even anymore, then there's an anterior tibia. Bend the knee, find the tuberosity, go inferior to the tuberosity. I place my finger, it's not in the textbook that way, but it's not very comfortable if you don't, because there's a piece of skin on a bony ridge. So I go through my finger, it's subluxated anterior, the liner drive is posterior. Make sure you're not on that tibial tuberosity. And for all extremities, well, I can't say that. For extremities, it's setting 2, but for the femur, I actually do setting 4. Okay. If it wasn't an anterior tibia, it could be a posterior tibia. Put your hand between the tibia and the table, and then you're stressing it posterior. You don't have to actually break contact with the table. An impulse is enough to stress it. And if you got the reactivity, to adjust it, you're gonna have 2 segmental contact points on each of the posterior aspects of the tibial plateau. So P to A and P to A. And then retest it and see if you got it. Stress it posterior, and it's even, so it cleared. Now I'm gonna check for externally rotated tibia. Grasp the gastroc and externally rotate. Now, how did I know I went external? The easiest way to know is look at their toes. The toes went external, the tibia went external. The book references the tuberosity. That's hard for people to visualize sometimes. So if it went external, to adjust it, I'm gonna set up on the tibial ridge on the lateral aspect. I'm not using my thumb or finger and going medial, lateral to medial on that tibial ridge because it had gone external and now I'm gonna take it back. And when I re-stress it, it's even. If it wasn't external, to test for internal, grasp the gastroc, and when the toes go internal, then the tibia went internal. To correct it, you're on the medial aspect of the tibial ridge, and the liner drive is lateral. So I'm going medial to lateral on the tibial ridge. And then you retest it medial, and it's even. Does that have medial and lateral shear on the sheet? Okay. Is the next one inferior patella? Okay. So I'm going to slip my hand in between the femur and the table and then pull down. As soon as you meet the resistance of the patella, that's about all you need because you don't want to grind on that patella. It doesn't feel good. And if it's reactive, then I just let them place their foot on my shoulder. I can use this hand now to find that patella and set up on the inferior pole of the patella, and the liner drive is superior. And you'll notice in the notes that you only want to have about 45 degrees flexion, not 90 degrees, because it'll pull the tendon too tight and you won't get a good adjustment. Then you would re-stress it inferior and see if it corrected it. Then we have lateral patella. So you're going to reach from the medial aspect and push the patella lateral. And if it's reactive, this one to me is a little tricky because to palpate it, I use both hands. So I've got the patella between the fingertips of both hands. Now, I know from my proprioception where the patella is, I'm gonna leave my medial hand and pick up the activator and go to the lateral aspect. So I think I got on it, and once I touch it, I feel it move with this hand so I know I'm on it, and then I can take this hand away. That's just to help me find it, it's not stabilizing. Then the liner drive is lateral to medial. And then re-stress it, lateral, and see if you corrected it. The two that are written up in the textbook that are on your notes is the inferior patella and the lateral patella. Can it subluxate superior? Yes. How would you test it? Stress it superior. You'll need them supine to adjust it. And can it subluxate medial? Yes, stress it medial. And you'll probably need them supine to adjust it. Okay. And then what's the next one? Head of the fibula? Okay, so we're going to the head of the fibula, which is here, and I want to stress it posterior and superior. So I just kind of crook my finger around it and do a combined vector in a posterior superior direction with a little wrist flick and look for the reactivity. To correct it, I'm going to go to the head of the fibula, and I'm going to stand on the other side so you can see. There's little flat ledge there that you can place your activator on, and it's subluxated posterior superior, so your liner drive is anterior inferior. And for viewing purposes, I'm standing on the other side, but you would stand on the same side you're adjusting. And that's the head of the fibula. Is that the last one? Lateral fibula. So mid-shaft, here's the head, here's the distal end. I'm gonna go mid-shaft, tissue pull, lateral, and look for reactivity. Again, don't set up way up here by the head, you're mid-shaft, and you're gonna take it medial. Does it say slightly anterior? No. So if you can't get it to clear when you recheck it, you can add a little bit of slight anterior on it, but for the most part it's medial, and then you tissue pull it and check for the reactivity. That's it.
You want to do psoas?
You can stop the video.